And good morning or afternoon. Here is our beginning of our two presentations on immune compromise. There'll be a presentation on immune compromise related to HIV and one related to oncology patients undergoing therapy. So those are the two classes that will be required for Thursday's class. So let's begin. Here's our objectives. Again, these are posted under the objectives and readings for the course, so please review those. A little bbit about HIV. The CDC numbers are a little older. I did not get a chance to update those, so you can imagine they are higher. HIV was first identified in 1981. By the late 80s, there were 100 reported cases, but there was more of it in the public. And by 2012, you see the increase in numbers throughout the U.S. Our big patients that are risk factors would be MSN patients, men who have sex with men. And particularly at high risk are young black men, and they're more seriously affected. The other kind of sad truth about HIV and AIDS is the medications that do work very well in it are expensive, and it's unpleasant to see individuals that really need medications to improve and do well sometimes cannot afford or access the medications they need to do well. A little overview of the immune system, and as you know from PathoPharm, this is our specialized systems that protect us from outside invasion. So it identifies who we are versus who is non-self or who should not be there. So here's our purposes, and it identifies and neutralizes any foreign invasion, and then disposes and destroys cells. It is felt to also destroy malignant cells, and at some point, if malignancies appears, it means that either the malignancies have figured out a way to hide themselves from our immune system, or our immune system is not recognizing the invading cell as a malignancy. When we talk about immunity, there's natural and acquired, so take a quick review of that. Natural would be all the anatomic chemical barriers, so your skin, the enzymes in your mouth, kind of the natural first line of defenses. Then acquired immunities are related to any particular invading organism or molecule where it's an antigen, and then we form antibodies to fight any further development or reappearance of the organism. The lymph organs, remember there's B and T lymphocytes. So the lymphocytes are our major responsive element of our white blood cells that detect and help neutralize invaders. If it's a bone marrow lymphocyte, then it's a B lymphocyte. If it's a thymus gland, then it's a T lymphocyte. So T lymphocytes is what we'll focus on, because that is our concern for the HIV human immunodeficiency virus. And the HIV virus is a retrovirus. That's the classification of the virus. The T lymphocytes can directly attack an organism, an antigen, or they also are helper cells that facilitate, and by biochemical signaling can call in other immune responses. So you see the subsets there. And the T cell we're looking at is that helper inducer cell CD4. So the CD4 T cell is the concern. So the pathophysiology of HIV would be that it's a blood-borne or serum-borne, and its initial presentation is quiet. So nothing really happens until there's enough presence of virus to affect the immune system and cause appearances of unusual infections. Here's the viral replication. It attaches to the membrane, enters the host cell of the T cell, uses the host cell's DNA to replicate its own RNA or DNA, and then causes production of the protein shell around it. And once it has sufficient numbers, then actually it kind of is released in the system by killing the T cell, and then the HIV, the virus, is released into the system. And the key element is that kind of everyday, or not everyday, typical infections that would not be problematic for most people become very problematic and life-threatening. A highly recommended video for you is in your web links. You will find a Scientific America Cells Alive link, and if you have time, take a look at this depiction of spiral invasion replication. The reason is it gives you a nice visualization. You can see number one is where the little virus attaches to the cell membrane, and then it's inserting itself into the DNA and then reproducing. The reason is that within this Scientific America depiction, it is showing you also how the medications work. So you'll see attachment. There's a medication that blocks attachment, Fusion. There's a medication that is a reverse transcriptase inhibitor. So there's a protease inhibitor. So you can see some of this in action, and also it shows you a little bit how the medications work, which is a nice visual. Also, who doesn't like a good cartoon? And Scientific America on top of it. So if you have a chance, please take a look. It's not very long, and you can click around in it and see the different stages of the invasion replication. Here are the risk factors for development of HIV, and it would be sexual practice with an infected individual, unprotected sex. These are our highest risks from semen transmission. Also blood and needle exposure. So these are all of our blood-borne universal precautions. You can see the risk is very low in our blood supply. Years ago it was not. We didn't have an ability to screen it. In the 80s we had several disastrous issues with families who had disorders needing frequent blood transfusions, so we can chat about that a little later. Occupational exposure, and I'll give you about 5 seconds or so to think about which occupations are highest risk. And you're actually seeing some of that right now with coronavirus. It's healthcare workers, it's first responders, it is correctional facility employees. So those are occupational exposures that are higher risk. And of course, prenatal exposure. It's cultured from breast milk, so babies should not be breastfed. And in the birthing process, vaginal delivery is a higher risk delivery procedure for the baby being exposed to HIV. Here's some of our classifications. So you'll see that we're looking at those CD4 counts. So the categories in regarding cells per microliter, these are the CD4 T cells. If above 500, they have a fairly functional immune system. Once it starts dropping into that 200 to 400 category 2 range, now the immune system is under a lot of stress, and it's more difficult for the individual to fight off infection. Stage 3 then would be classified from HIV infection to AIDS. So now this individual would actually be in the acquired immune deficiency syndrome. So our 3 stages, which we'll look at in a little more detail, would be the acute, asymptomatic, and then the symptomatic. Here's our definition by the CDC. They either have to have fewer than 200 CD4 count, or they can be classified as having AIDS if they have 1 or more AIDS-defining infections. So that would be, it says PCP, but it's really PJP. They could, which is pneumocystis. They could have cytomegalovirus or Mycobacterium avium complex. So there, we'll look at some of those in just a bit as well. But the whole issue is they have 1 or more of the infections that are related to immunocompromise. Here's our testing and diagnostics. Now, there are some quicker testing methods out there. The standards are the ELISA and the Western blot. And typically the screen is with ELISA. And after the screen is done, if it's positive, the individual is always told, we need you to come back for confirmative testing. And it could be, there's false positives that happen. So that's why we have to be careful. This could be a life-altering diagnosis. So initial screening, if it's positive, we would just ask the patient to come back for confirmation, and then a second ELISA and a Western blot, and is confirmative. The antibodies that are detected by the testing actually don't form or aren't detected until about, you see, there's 6 weeks to 3 months in most patients. So if an individual has had a sexual assault or unprotected sex and there's a revelation that, oops, I have AIDS, and they come the next day, they will not be able to identify whether they are infective or not. So it's wildly stressful, but they need to wait and see and be tested later for confirmation. The other thing beside testing for the antibody testing, they will look at viral load, and that viral load actually means how much virus is in the patient's system. So the two kind of diagnostics after the antibodies testing would be to track and then trend the viral load and the CD4 counts. And here's some more information on the diagnostics. The plasma HRV RNA levels, which is the viral load, indicates the risk for really falling into the AIDS category. So if there's less than 10,000 copies per milliliter, it's really felt as to be a low risk. That's a small amount of virus. And you can see how it jumps until there's like 100,000. So that's a high risk. That means there's a big viral presence and probably a lot of destruction to the CD4 count. The CD4 counts then are based on that 500 and 200, and you can see if greater than 500, they'll want to be monitored maybe twice a year. And then once it starts falling below that, then there's more monitoring that's going on. Here's our symptoms. So the acute infectious stage. If you look at those, what does that look like? Kind of looks like a typical sore throat, looks like strep, looks like mono. The lymph nodes go up. That's not unusual with mono. So individuals typically are not automatically screened for a virus at this point if they're within the window that they could be screened. But if the patient indicates there's high risk factor, then a screening might begin once they could be identified as positive. Here's our asymptomatic phase. So the acute infection phase kind of passes away, the patient feels better, and they become asymptomatic. Now they're still very contagious, and again, this is kind of a dangerous phase, that the individual is contagious but not showing a lot of signs and symptoms. No symptoms, or they kind of have that malaise. Their CD4 count is falling, they're positive for HIV. The lymph nodes remain up. So once someone has HIV, their lymph nodes, once they enlarge, they don't go down. They're just kind of always enlarged. And finally, once they become symptomatic, and symptomatic can be years, their lymph nodes have stayed up all this time. They're really showing the fatigue, weight loss, fever, kind of that night sweat presentation. And then which opportunistic infections are showing up as their CD4 counts drop. If someone is presenting as a possible HIV patient, we'll do a careful patient history. look at any complaints they've had, any unusual infections. Rashes are kind of a dermatologic presentation. Wound healing. Lungs are a sensitive area, so they sometimes present first with pulmonary issues. Again, the lymph nodes should be elevated. Their liver and spleen will be up. The spleen due to the kind of the immune effect. Their nutritional status might not be great, especially if they've got kind of that blah and malaise and fatigue and just have no appetite. Then the disease progression is very unpredictable. There's some patients that they're kind of called, they're our super patients. There's not too many of them, but they've been infected. They were infected a long time ago before there was medications available, and they've done well. There's something about their genetics or their immune system has kept them in good health for a long time. But it can progress very quickly in some people where the virus really overruns the immune system. You can see the asymptomatic phase can last for years. And during this time, individuals are highly infective. If an individual can be identified when they were infected, they're not being treated, and then being labs being drawn within the first year of their disease, if we can see that viral presentation at that point, that's kind of a good indicator of how the disease will progress. The viral set point, if it's low within 6 months to a year, that means this person's immune system is a little more vigorous and is fighting off the virus. If it's really overwhelming them, this individual will not do well without medications. So here's the progression. Opportunistic infections appear. Now this is without therapy or with wrong therapy. Lots of different organs and clinical symptoms, and again, pulmonary symptoms often lead to our first diagnosis. In the 80s when I was practicing, I was in Arizona at that time. We had a few patients that came in with these horrible, horrible pulmonary infections. I mean, it was not quite coronavirus with the amount we were seeing, but when they'd come in, it'd be coughing up bloody sputum and horrible SATs, and they were, they would die quickly. There wasn't much we could do about them. And those were some of our first AIDS patients, but that was like scary time, kind of like hazmat suit time too. People just did not have the information as far as what was going on and how this disease was progressing and what was, how contagious it was. So let's look at some of our opportunistic infections. Again, let's start with the pulmonary system. And what you can see here, there's some little holes in the lung. So this is like different cavitating little holes where the infection, and this is the pneumocystis, kind of gets in and burrows and is damaging the lung. And when the patient coughs, it's blood tinged. There are various microorganisms that can be involved, but this was something that it was like, why are people getting this type of pneumonia? So the thing is, it used to be classified as a bacterial, and it took years to figure out it actually is acting more like a fungus, but whatever classification it is, it's very unusual. And actually the PJP or PCP is in the environment. We don't get it because it's not very vigorous, but with people who have their immune systems depressed, it gets in there and it does a lot of damage. So it produces these cysts, it damages alveoli, it kind of overwhelms the lungs, and they were passing away from this. So atypical pneumonias and TBs are getting in there and really taking advantage of the situation. So this is pneumocystis jirovecii pneumonia, or PJP. And as you see, this is one of the more common severe infections. Again, this is with with the immune system affected. So it's found in the air, and food, on water. It's mostly airborne. And whenever I do this in this discussion in class, people are always like looking at their desks and looking at their hands and wondering if they should breathe. And the answer is yes, you can breathe because you don't have this level of immune depression. And symptoms are very similar to any alveolar injury, and they can diagnose it via lung biopsy or sputum. And now I'm not going to ask you to memorize the medications. These are the real typical medications for this. Bactrim and Septra are typically used for like urinary tract infections, but this is a sulfa-based medications. They do very well on that. The big thing about the medications as we go along is you'll notice how much side effects they have. So this is a real, the patient is sick, and the medications are hopefully going to do well without making them too ill. So that's our pulmonary fungal infection. Let's look at pulmonary bacterial, and that would be Mycobacterium. Even if patients don't have it, the CDC recommends screening for it because they are susceptible to TB. Here's our symptoms. We had this in PathoPharm. Those night sweats, that cough, hemoptysis, fevers, and the diagnosis would be TB tests and sputum. Medications we talked about before were the isoniazid, the rifampin, and if you remember, both of these are long-term medications, like 6 months or more, especially with someone who's immunocompromised. The big issue for teaching with these patients is to please comply with the drug regime, because if they decide to take a break for a week or two, then we have a chance of TB drug resistance showing up. The bacteria doesn't get as much to kill it. It kind of wounds it, and it's able to rebound and develop resistance to the drug. So here's some TB in a patient. It's not necessarily an HIV patient, but it's really has these big, like, cavitating lesions. So you'll see a big lesion as you're looking at the x-ray. It's on your right side, upper right lobe, where you'll see a lesion. Now, the swirly things are, I think those are electrodes. Don't worry about the little swirls. But this is a TB presentation. There's also some scattered along the other lobe. So it's the patient's left upper lobe that you'll see the lesion, and then scattered throughout the right lobe along the spinal column. GI system, lots of GI problems, and the GI system goes from the mouth to the rectum. So lots of opportunistic infections there. We've got thrush going on in this picture. There can be Epstein-Barr viruses. There can be esophagitis. The big issue is these patients might be nutritionally deficient anyway, so this could result in diarrhea. The thrush and infections of the mouth certainly make eating painful. It's malabsorption syndrome, and it adds to the HIV wasting syndrome if they're in declining health. Here's our thrush. You can see this individual saying ah. So we're looking at his tongue, and on the very top you'll see his upper lip and his like 2 front teeth. But those curd-like patches are the fungus. That can be painful. So when we get to like mucositis related to chemotherapy, we're going to talk about erythema and ulcers, not necessarily thrush, but like oral irritation. And basically it's like soft toothbrushes on the teeth. Stay away from the plaques. If they want to rinse their mouth, fine, but just like gentle water or mild saline, no alcohol as far as like mouthwashes. The medications, you'll see these are the antifungals, and typically they have very good swish and swallows, which actually reduce the fungal infection within a few days. It's very effective. There's some like troches or lozenges they can suck on. There's some oral medication as well. And the big issue is, well, if they're having a big breakout, to make sure their food choices are helpful for the patient. Soft foods, cream soups, things that are not going to irritate the oral lesions. A couple comments about the nervous system. So we have toxoplasmosis gondii, and toxoplasmosis is very common in cat litter. So you would guess, and this is also a no-no for pregnant ladies. So you would expect this person, if they're not saying get rid of the cat, but they are saying don't change the cat litter. So any individual with a cat would have someone need to come in and do the cat litter for them. Herpes simplex also crosses the blood-brain barrier and can cause severe neurologic damage. It can result in some chronic meningeal inflammation and different central nervous system signs. And if severe enough, can cause like this really dulling due to the encephalopathy from HIV. This is just a little bit more information on toxoplasmosis. You can see the transmission, and it has concerns for the central nervous system. So one thing we would teach them, and we'll see this when we get to immunosuppression with chemo, is no raw or undercooked meats, good hand washing. It also can affect fetal development, and that can be very devastating. It says central nervous system, they have large heads with hydrocephalus. It's very unpleasant. Herpes simplex, again, same thing. This can cross the blood-brain barrier and cause central nervous system dysfunction. This is just a picture of a child, and this is not due to HIV or AIDS, but I wanted to show you how the herpes simplex can get along the eye, and then it actually can like run onto the optic nerve and into the brain. So this child would be watched very carefully and obviously be on antivirals. There's some additional viral infections. We just talked about HSV1. It can also be the genital herpes treatment, as you would guess. There's the VIR at the end of the medication, acyclovir, so antivirals. Here's another medication, another opportunistic cytomegalovirus. And this again has neurologic implications. Again, can attack the optic nerves, and you see that these are all antivirals. The foscarnet did not have the VIR at the end, but the others do. Skin, there's a lot of rashes that appear in patients with the HIV, the virus. These roseola or macular eruptions. Now, I know in assessment you probably talk about macular versus papular. And macular rashes are those that are rashes that are flat. If you closed your eyes and took your hand and ran your hand across the skin with the rash, you would not feel anything. If it's a papular eruption, if you closed your eyes, you would feel little bumps. So these are raised rashes. So macular roseola, or like skin rashes that are red, are fairly common. And you can see dermatitis, what happens in the HIV population, really allows for a lot of the immune system blunting, allows for a lot of skin irritation. Here's a Kaposi sarcoma, so this is an integumentary system, but this is also cancer. And this is an very unusual sarcoma, but it is not uncommon in HIV patients. Again, this kind of goes with the immune system in cancers, that there's something about our immune system that protects us against cancer. And hematologic as well. So here's our hematologic system. So here's our different not dysfunction. Here's some labs that we would be looking at. So thrombocytopenia, we are looking at platelets. Anemia, obviously, we're looking at H and H. Neutropenia, we're looking at the white cells, and we're specifically looking at the neutrophils. Again, those are all low counts. The cardiovascular system in general, a lot of inflammation, itises. The right ventricle can be enlarged if there's a lot of pulmonary issues causing increased pulmonary pressures. You can see this is really devastating to all systems of the body. A few other ones: endocrine, musculoskeletal. Here are the HIV-related cancers then. We have Kaposi's, which I just talked about. It's their most common. It can be found in the mouth as well, on the tonsils, and treatment is radiation or chemotherapy. Now, as far as the pharmacology, I'm not going to need you to know a lot of detail on it, but I just want you to have a good overview of the different medications that are offered for the patients. So here's our classifications. We talked about the virus enters by fusing to the membrane of the healthy T4 cell, a CD4 cell, and we do have a medication called Fusion that prevents the binding. So that's one way, one medication, one approach. They are NRTIs, or nucleoside reverse transcriptase inhibitors. So you see ACE in there, so we've got an enzyme involved. It interferes with viral replications. These are some of our older medications. They're still, well employed, but this was some of the first methods that science used to explore the replication and find medications to block the replication of the virus. And NRTIs protect the non-HIV infected cells, and these are non-nucleoside enzymes, reverse transcriptase inhibitors. And then we have the medications that prevent protein synthesis, and those again are very helpful. You can see they all end with VIR. That's an antiviral. So a little bit on each one. The Fusion, it's newer. You can see it had a big cost when it first came up. I haven't looked recently to see what it is, but it inhibits the fusion of the membranes. It's injected twice a day, so it's not an easy medication as far as administration. The NRTIs interfere with viral replication, and the purpose of this slide is really not to have you memorize the different medications. I wanted to present a couple of them to you, the AZTs, the DDI, and all that. But they do have some unpleasant side effects. So the whole issue with the viral inhibitors is sometimes the medication is going to be very helpful, but patients might have the unpleasant side effects that go along with them, and it might be discouraging for individuals to continue on their medications. Here's the NRTIs and the protease inhibitors on this slide. And you can see, again, some rashes, drug interactions with the NRTIs, and kind of unpleasant side effects with the protease inhibitors. But those are the purposes of the medications. Those are how they work. And then a lot of it is finding the right combination that works for the patient and is the least unpleasant side effects. So the medication therapy is typically designed as HAART, or HART, highly active, and it's a cocktail. It's like a combination of 3 to 5 medications. So it is employed to suppress the virus And if that happens, then the immune system can kind of recover and depress the viral load and elevate the CD4 counts. So if you're interested in this, there are FDA-approved medications. There's many more than these out there for you to look through the FDA. There's a new medication that is on the television and on the media. It's called Truvada, but it's a HIV prevention for patients, individuals that might be high risk, and this helps protect them. So this would be yes, there is something out there. It is a preventative or prophylactic medication. Please discuss with your physician. And I really won't be holding you to any of that since it's a newer medication and very unlikely to be on the NCLEX or HESI. But if you're interested, this is the name of it. It's called Truvada. Now, with the medications, you saw that they might have a lot of side effects. So there's always this debate back and forth as far as when to start antiretroviral therapy. Is it immediately? Or do we wait a little bit? So the pluses are, obviously we can keep the viral load reduced. It prevents progression, and it delays conversion from HIV status to AIDS status. However, there's a lot of side effects to the medication that can affect quality of life. The earlier we throw medications at something, the more likely it is to develop drug resistance. And we haven't been able to do like an immunization against HIV because it is constantly mutating. So that would be the great thing, is just get the HIV virus immunization out there, and it's been stymied all these years since the 80s. Also, there's if the medication, if the virus becomes resistant, then we have risk of disseminating the virus in a drug-resistant form. Some of the newer medications, we don't have a lot of long-term toxicity, and we don't know how long the drug will be effective. So if we deploy it too quickly, the risks show up. If we don't deploy it too quick, if we deploy it quick enough, then we enjoy the benefits of it. Here's a little schematic that kind of summarizes indications for initiation of therapy. You can see if they're asymptomatic, they've got a fairly decent T-cell count, their HIV count is low. The recommendation after discussion with the patient and the provider might be, let's defer, or the patient might say, I've got some friends who are on those medications and it's not going well. So they might say, well, let's see you in 3 months and get a better reading on your infection, and we can go from there. If the if the viral load is starting to rise, now it might be, let's start considering. Definitely, if their count falls below 350 and they're approaching 200, they really want to offer treatment. That's getting kind of dangerous. Their immune system is getting too compromised. And symptomatic, it needs to be treated. So that's kind of the definitive treatment option there. For complications, we look at the CD4 count. As it falls below 500, there's more likely to be symptoms. Below 250, definitely. We just talked about some of the complications, but this is when HIV moves into the AIDS status. There's some nursing diagnoses we need to be concerned about for our patients. Actual or risk of infections, fatigue, the management, especially if it's 3 to 5 different medications, and they have different, maybe they might have even some underlying disease processes. There might be a lot of medications they're managing and therapeutics they're managing. Our goals, you see there. So it's to keep them free of infection, keep their weight, at an appropriate level and avoid risk-taking behaviors so they keep themselves and others safe. And we've got some common nursing interventions here, preventing infection. I think by now we know this. It's all about aseptic technique, hand washing if they're in the hospital, but also we have a neutropenic diet. And you see, good labs and just standard precautions. You don't need to get into hazmat suits to go in the room. Neutropenic diet, think about what that is. It means it's a diet recommended for individuals who have reduced immune systems or reduced effectiveness of their immune system. So that would be, you have to be careful with fresh fruits and vegetables. Salad bars, when they open again, would be a no-no. It also would be no raw meats or fish, so sushi would not be allowed. And they would just have to be real careful with any fresh items that might be contaminated with bacteria. Promote nutrition. You see high calorie, high protein, small feedings, and that really is helpful for people that don't have a good appetite. Good hydration, anti-nausea medication. So if I were to ask you what are some good high protein snacks, you should have some ideas about that. And I'll give you a few hints. So snacks could be anything with peanut butter or nut butter. High protein diet could be anything with legumes, beans are good non-meat sources. Meat is a great source, so sandwiches would be good. Fish would be fine, chicken, eggs, egg products, yogurt is great. So think about some of those as far as what you might recommend that would be tasty for someone to, it doesn't have to be an AIDS patient or HIV patient. It could be anyone who needs a little bit of bump in their protein. Some other nursing interventions regarding activity, therapeutic management and risk behavior. Some legal and ethical issues. We do not get to pick and choose who we want to take care of, so it is illegal and unethical to refuse to care for them. Also our HIPAA laws reminder, they have their rights to privacy, and employers' policies, be aware of your policies. If a nurse decides to not care for a patient, they could be subject to termination. Here is our case study for HIV. For this presentation, we will discuss this in class. There are a couple questions related to this which appear on the study guide, so please look at that and we'll pick up those questions and discuss those during class. As far as infants and children, several years ago, the previous PEDS instructor asked me to just pick this up, so I told her I'd be happy to. We have a risk of HIV transmission to newborn. So here are risks. Women with a high viral load, of course, would have more virus to potentially affect the baby. If they're on antiretroviral therapy and either decide the side effects are unpleasant or they can't afford that, that would certainly be a risk. If they convert during pregnancy to HIV positive status, vaginal delivery, you would think, if any of you have seen C-sections, which I'm assuming you have, you know they're kind of bloody affairs. So it's like, why would a vaginal delivery be worse than a C-section where there's blood all over the place? Well, during a vaginal delivery, it's possible that the child's skin could be disrupted during the delivery or scratched or scraped or whatever. So C-section is definitely preferred. So no maternal, like scalp electrodes or anything like that where we break the skin and can contact the baby to the mother's blood. Prevention If for some reason they're in a long labor and haven't had a C-section, then that's more concerning. If they haven't received appropriate obstetrical care, if that would be a risk. If they do get appropriate obstetrical care, that's a plus. If they are on zovudine or AZT, sorry, that actually is a very helpful medication to help protect the baby, and then they continue it for about 6 weeks. At this point, there haven't been any negative effects of the AZT for 6 weeks, but we're still working on long-term effects. Definitely no breastfeeding, bottle feeding, and this is a huge concern for underdeveloped countries where if the baby doesn't get breast milk, the baby's going to die. So the choices are fairly awful with that population. For exposed infants, they should be getting their good well child care, and you can see all the routine immunizations, H&Ps. Again, no breastfeeding, the AZT we talked about, and usually it's 18 months until they can be definitive that the baby is not HIV positive. Here's some populations. You can see that second bullet point, children receiving blood products before 1987. That would make them in their 30s, but this was a huge, horrible part of the HIV outbreak that was occurring in the 80s, and there were whole families, children wiped out, which was just appalling. But there are a couple families where the children all had some form of hemophilia and had to receive like the clotting factors otherwise they would have terrible bleeding episodes and be at risk from there. So the clotting factors are usually taken from multiple donors, and then they're pooled to get enough clotting factor to give the individual. It could be like 500 or 1,000 donors to make one good infusion of clotting factors. So as you might guess, without being able to identify if any of the blood products were contaminated, these children were developing and dying from HIV and AIDS. So it was a horrible part of our health history. Otherwise, it's children exposed perinatally and adolescents affected through either needle sharing or sexual activity. With younger children, it's that whole failure to thrive. They're not growing, they're not developing, they're not meeting their milestones, and you see some of the other clinical findings there. For HIV-infected children, they will usually start with some of the HIV medications. They can give gamma globulin to support the immune system. And then it says no oral polio or chickenpox immunizations, so they should not get those. And you're probably like, what is wrong with her? There is no oral polio out there anymore. Well, there are oral polio immunizations in less developed countries, so we don't give them here, but they're available elsewhere. A lot of the same thing for children as we see for adults. Good management, good pain management if that's an issue, nutritional support, and family support. The family's going to have to be helping run the therapy for the child. And that's our presentation on HIV AIDS. If you have questions, get those ready for Thursday. And then also please take a look at our oncology presentation. And also for oncology, you must watch the additional PowerPoint, the link that I put in the, I think it's in web links, but there's a study guide with an instruction. The physician presenting the complications for chemotherapy, or not chemotherapy, for cancer, the acute complications is very good. It's very specific, and I've created just a document to take notes with that. So definitely make sure you look over that, and otherwise have a good morning or afternoon. We'll chat with you again.